Hi everybody, good evening, welcome back. So today we are going to start off with what is called as neck. Before that we'll just complete one section of neurosurgery which was remaining. So neurosurgery is quite interesting. We saw many of the things previously, but now we'll just surf through some factual things in neurosurgery, and with the help of that we'll actually be able to complete neurosurgery and then start with the neck. So whenever you are grading any brain tumors, so what WHO has told that any grading of the brain tumor can be done on basis of grade 1, grade 2, grade 3 and grade 4. So grade 1 is nothing but a slow progressive tumor which is predominantly a benign tumor, and it has excellent prognosis because if you are going to remove that tumor, the cure rate is going to be 100%. So it is going to have an excellent cure rate, and grade 1 is the only tumor that does not recur. That is why grade 1 is called as a good prognostic tumor. And which is the tumor? It is a pilocytic astrocytoma. So pilocytic astrocytoma is seen typically in young males or typically in young babies. So what they have told is nature is great. So nature is going to give the curable diseases to the child. So that is how we are going to see here that pilocytic astrocytoma is typically going to be seen in small children. Grade 2 is seen, it is slow, but it is infiltrative. So it might not grow very fast, but it is infiltrative. It is going to infiltrate in the surrounding regions, which is like a diffuse astrocytoma. So pilocytic comes in grade 1, diffuse comes in grade 2, and median survival is 15 years. But if you are not going to treat the disease in good amount of time, it is going to eventually come into malignancy. Grade 3 is anaplastic. So here the cells are now getting anaplasia. Anaplasia means loss of differentiation. The cells are not going to be properly differentiated. They will not be properly differentiated, and that is the reason they are going to be anaplastic astrocytoma. So grade 1 is pilocytic astrocytoma, grade 2 is diffuse, grade 3 is anaplastic, and median survival here reduces to almost 2 to 3 years. And then comes the grade 4 tumor, which is called as glioblastoma multiforme. So here you can see that these are the blast cells. So glial blast cells, the name itself tells you that these are the glial and blast cells. So blast cells are premature or precursor cells, and these are not going to be a proper differentiated cells. These are going to be malignant cells, and median survival is not more than 14 to 16 months. So as we saw, grade 1 excellent prognosis, grade 2 10 to 15 years, grade 3 2 to 3 years, and grade 4 14 to 16 months. So whenever a histopathologist is going to give you a report of any brain tumor, just see what type of grade he is giving off. So what I told you, pilocytic astrocytoma, diffuse, anaplastic, and then comes the glioblastoma multiforme. So you know 4 types of brain tumors according to the WHO grading system, and hence you can actually tell the patient that what is going to be the prognosis of the patient. So always remember that grade 2 and grade 4 eventually will recur due to the infiltrative nature. So even if you are going to go for a proper resection, grade 2 to grade 4 tumors, so 2, 3 and 4 tumors are going to recur. Hence you should always plan them for some concurrent chemoradiation. So whenever you are treating any brain tumors, whenever they are grade 2 to grade 4, that is the time when the oncologist will suggest some amount of chemoradiation to the brain. So because whenever you are going to resect the tumor cannot be taken out as a whole. There might be some leftover tumor cells, and that can again start multiplying and the tumor can recur. So glioma, as I told you, these are the glial tumors, so high yield points. So most common presentation these tumors are going to have is going to be a focal seizure. So the seizure is going to start at the region where the tumor is going to be present. And always remember that as in trauma, we saw that the first line anticonvulsant was levetiracetam. Same way here also we are going to give levetiracetam. It is going to be first line treatment for epilepsy always. But in trauma we saw that if levetiracetam cannot be given, you can give eptoin. But here there is no role of eptoin. Levetiracetam is the first line tumor related epilepsy. Later on we saw that it is going to raise the ICP, and progressively the patient will have the focal neurological deficit. The patient is going to have paralysis or paraparesis of the region. ICP management, here we know there are 2 types of brain edema. So before going ahead, we will tell you 2 types of brain edema. So what are the brain edemas? So it is either vasogenic or cytotoxic. So cytotoxic means whenever there is going to be trauma, whenever there is going to be some inflammatory reaction near the brain, there is going to be cytotoxicity, and the vessels are going to become leaky. So whenever the leaky vessels are going to be there, it is called as a cytotoxic edema, and it is not responsive to steroids. So it is not responsive to steroids. But whenever you are talking about vasogenic edema, it is because the blood vessels are going to multiply in the region. Why are the blood vessels multiplying? Because there is a tumor and the blood vessels are naive. They don't have proper barrier, and that is the reason it is going to develop edema. And here it is going to be effectiveness of the steroids. So always remember that brain tumors, because of new blood vessel formation, there is going to be edema, and that edema can be very well controlled with dexamethasone. So ICP management, here you can use high dose dexamethasone. It is going to reduce the peritumoral edema, and always remember that dexa shot is given before starting off with any brain surgery. Most common grading where we encounter the tumor are grade 3 or grade 4 gliomas, and as we told that the grade 4 glioma can always be what you can say confused with brain abscess. So always and always you are going to do what is called as a diffusion weighted image MRI. So diffusion weighted MRI is going to tell you if the tumor is going to be a malignant tumor or is it going to be a brain abscess. And always remember, when there is the speech area involvement, typically if you are a right-handed person, your speech area is in the left side. The left Wernicke's and Broca's area is going to be the speech dominant region. So whenever you have the tumor, whenever you are going to encounter a tumor there, always you are going to do what is called as a awake craniotomy. So craniotomy is done under sedation plus local anesthesia, and that is the time when you are going to go for MSR. What is MSR? So MSR is equal to maximal safe resection. So maximal safe resection. Why? Because you don't want to damage the tumor. You don't want to endanger the life of the patient. You don't want to add morbidity to the patient. You need to cure the patient as much as you can without adding any morbidity. That's what we talked about in the principles of oncology. So you are going to go for what is called as a maximal safe resection. So before going ahead, there are some glioblastoma hints which are there typically for surgery residents. It is very much important. So there are few mutations seen in the glioblastoma multiforme. So IDH mutations are typically present in glioblastoma multiforme. So there are two types of IDH mutations. So IDH mutations, when it is going to be IDH mutant type, it is going to have a better prognosis. But if it is IDH wild type, so whenever the mutation is wild, it is like a wild animal, so it is going to spread rapidly and it is going to have worse prognosis. Another, we know that there is a methylation, MGMT promoter methylation, and it is going to predict the response to temozolomide. So these are few MCQ things which might be asked to you in the super specialty exams. Rare chances that they might be asked to you in your NEET PG, but these are few things which you should be knowing. Again, there might be some EGFR amplification. Again, we know that there are some agents which are going to act on the EGFR, like bevacizumab. So whenever you are going to encounter the mutations, whenever you are going to go for molecular studies, you can find out the mutations and accordingly you can plan specific chemotherapy for the patient. And always remember, standard glioblastoma multiforme treatment is going to be maximal safe resection. Don't go for radical resection. You cannot excise whole brain together and then you are going to give radiation to the brain, 60 gray radiation. And if you can add, if you think that it is going to be a methylation mutant, you can add a temozolomide chemotherapy, and that is going to suffice the treatment. That is, if you can remember, it is called as a Stupp protocol. So it is given in Bailey Love, so I've just mentioned it as it is. So other brain tumors which are typically benign, not developing from the glial cells. So these are meningioma, develops from the arachnoid cap cells. So from where does the meningioma develops? From the meninges, but which layer it develops? From the arachnoid cap cells. These are usually benign. These are grade 1 lesions. That's what we saw. These are grade 1, slow growing, and they might have an anaplastic variant. So after the resection, you might found that it is grade 3. So that is the time you can actually go for a radiation, or else only excision of meningioma is more than enough. So observe if elderly patient. So I had one small experience to tell you. When I was doing UG in my UG college, there was an orthopedic surgeon who was working as a trauma specialist. Quite aged, 70 years old man. He was a really gentleman. He taught me a lot of things in trauma. So he had that meningioma, and remember, he used to celebrate his 2 birthdays. When there was his birthday, and I consequently encountered that why is he celebrating 2 birthdays in a year? So actually he landed up into a cardiac arrest when he was at the age of 57, and then he was revived by giving a CPCR. And you know that after giving a CPCR, revival is very much less. You know that even if after giving good quality CPCR, the patient's chances of revival are still low, but he survived that. His ejection fraction was only 18 to 20%, and he had a meningioma which was encasing his optic nerve, and because of that he had progressive loss of vision. So he taught me a lot of things. Sadly, he is not amongst us today. I really miss him because I have learned a lot of things from him. But the thing is that meningioma is a benign condition. You don't need to treat it like malignancy. You don't need to treat it like malignancy unless you suspect that it is a grade 3 meningioma with some anaplasia. And meningioma develops from which cells? Typically from the arachnoid cap cells. Then there is a tumor called as a pituitary adenoma. So how does the pituitary adenoma typically present? It is going to present with blindness. Why is it going to present with blindness? Whenever it is going to grow in size, it is going to compress the subsequent optic nerve, and that optic nerve is going to cause blindness, and most commonly it is going to arise from the anterior pituitary cells. We know that posterior pituitary, this is the hypothalamus and this is your pituitary. So this is the anterior pituitary and this is your posterior pituitary. The posterior pituitary, most of the hormones from the posterior pituitary come from the hypothalamus. So they are stored in the posterior pituitary, and anterior pituitary contains its own hormones like growth hormone, like prolactin, like ACTH. So these are the hormones which are produced by anterior pituitary. So whenever it is going to compress, it is going to cause optic nerve problems. What is that called as? It is called as bitemporal hemianopia. Bitemporal hemianopia is what the patient is going to present to us with. So always remember, whenever an optic pituitary tumor is going to present, first you are going to categorize whether it is a microadenoma or a macroadenoma. So microadenoma is naughty. Whenever the patient is going to come to us with microadenoma, he is going to come to us with some hormonal disturbances. So I'm going to tell you an example. A 50-year-old female is going to come to you with sudden onset galactorrhea. There is no other complaint, only galactorrhea in the breast. You do a local breast USG, it is normal. You go for local examination, normal. When you go for estrogen, progesterone, they might be suppressed and prolactin levels are high. And then you do an MRI of the brain and you are going to find out a microadenoma. So here, if it is a microadenoma and not causing any compression symptoms, you can give dopamine agonist, which is called as a cabergoline. But if it is going to be symptomatic, as in sense it is going to cause some anatomical distortion, not the physiological distortion. An anatomical distortion is where you are going to go for a transpenoidal surgery. So here you can go for a transpenoidal surgery, and always remember, whenever you are going to handle a pituitary, the patient might land up into excess of ADH or reduced ADH. So it might be an SIADH or a diabetes insipidus. So whenever the patient lands up into SIADH, go for fluid monitoring. And when it is going to be a diabetes insipidus, you are going to add the patient desmopressin nasal spray. So whenever you are going to encounter pituitary adenoma, two things you are going to ask. The first thing you are going to ask, if is it anatomically, is it a problem, anatomical problem or a physiological problem? So if anatomical, go for resection. But if it is physiological, then you can go for hormonal therapy. So what is anatomical problem? It is going to be bitemporal hemianopia. Sir, vestibular schwannoma. So one very good piece of advice which I heard from the HOD of neurosurgery where I was doing my UG. Why is vestibular schwannoma present only in maximum amount of 8 nerves? There are so many nerves in the body, but why only 8 nerve will have that vestibular schwannoma? Because it is the only nerve in the body, or it is the only cranial nerve in the body which has some component which has some exposed section of pure nerve. So we know that nerve contains the myelin sheath. So any nerve is going to have myelin sheath, but only 8 nerve has some amount of exposed draw nerve surface area near the cerebellopontine angle. So whenever the patient is going to have some irritation, or whenever this region is going to be prone for a tumor, there is going to be formation of a schwannoma, typically in the region of 8th nerve. So there is going to be unilateral sensory neural hearing loss plus tinnitus, and always remember the cutoff criteria for resection is 4 centimeters. So if it is more centimeters, you have to go for a resection, or if not, the slow growing tumors can be observed. If asymptomatic tumors can be observed, or there is something called as a gamma knife surgery. So we know that normally our radiations are X-rays, these are ionizing radiations, but now there are gamma rays which are going to go for, where we can use this gamma knife for excision of tumors which are going to be more than 4 centimeters, and where we cannot undergo any craniotomy. So craniotomy, if contraindicated, you can go for a gamma knife surgery. The results might not be as good as an open surgery, but always remember that they will not cause any morbidity like an open surgery, like an open craniotomy. So always remember, brain metastasis, it is because of hematogenous spread, because brain does not have any lymphatic supply, and most common are from the lungs more than breast. So always remember, brain metastasis, 2 organs to be remembered, lungs and breast. Colon, melanoma and renal, it's okay even if you don't remember. And always remember that whenever there is going to be a metastasis to the brain, the whole brain radiation therapy should be given to the brain, and if any tumor is still remnant, then you can go for surgical excision for single accessible met. So if a single accessible met is there, if it is not there in the skull base, it is there at the temporoparietal region, so you can go for a local excision of the the metastasis. But if it is going to be there diffusely, you have to go for whole brain radiation therapy. That's what is very much important for you to know. So now we are going to talk something about interesting topic, which is an epilepsy surgery. So remember what happens is epilepsy means, so what is the difference between a seizure episode and an epilepsy? So a seizure is an unprovoked, uncontrolled actions of the body, but whenever it is not associated with any anatomical cause, it is only a pure physiological cause, it is called as an epilepsy. So epilepsy means it is physiological. So why does it happen? We don't know the reason, but because of recurrent episodes of epilepsy, what happens is the patient's hippocampus undergoes a sclerotic change. So by the time the patient reaches the age of 25 to 30, his hippocampus undergoes sclerosis because of epilepsy. So the actual detail of the mechanisms are not known, but because of that sclerosis, now again the epilepsy attacks are going to recur and increase. So it is going to be a vicious cycle. So this epilepsy is going to trigger hippocampal sclerosis, and this sclerosis is again going to cause seizures. So always remember, you have to break the chain, and that is the time you can go for hippocampal excision. So whenever the hippocampal sclerosis is most common cause of temporal lobe epilepsy syndrome, and it is because, and then it is going to go into a generalized seizure if it is not treated. So always remember, you have to localize the lesion using the EEG, because we know that without EEG we cannot localize from where the seizure is coming just based on the MRI. So useful for seizure characterizations. And always remember that EEG can be done in two ways. Intraoperative EEG can be done by placing the electrodes inside the cranial cavity. Normally we know that EEG, the electrodes are placed on the forehead, but whenever you know that whenever you are going to operate the patient, intraoperatively you can go for subdermal electrode placement. So it is superior to scalp to localize the epileptic focus. And here, whenever we know that the patient's hippocampal lobe is sclerosed, you can go what is called as a temporal lobectomy